Welcome. Thank you all very much for joining us this evening. So this webinar is on what to consider when buying a diagnostic ultrasound system. So before we get started, if you have got a webcam and can put it on, it helps for better interaction. So if you don't mind doing that, that would be good. I know some of you have got it on now already. And if you do have a question, we want as many questions as we can get through in the hour. So just put them in the comment section on the left-hand side, sorry, on the right-hand side. And we'll do that. Also, I think some of you have got your microphones on mute. If everyone could just put themselves on mute apart from Chris and Rob, then it just avoids any background noise. And then if you've got a question that you want to ask, then we can go into it from there. So this topic area has been really popular. We've had loads of interaction. And mainly because there's so much to consider when you are purchasing or considering buying a diagnostic ultrasound system. So choosing a system is a real minefield. So hopefully this session will really assist with your decision making as and when you're looking to buy. So sadly, Mark is not able to join us. Well, he may join us later on, but we've got Chris Myers, who's clinical director at Complete Physio and is also co-faculty lead for the sports medicine ultrasound group. And we've also got Rob, who is the clinical director of Waterside Physio and is also co-faculty lead for the SMUG group as well. So welcome, Rob. This is the first time I've actually interacted with Rob, so good to see you.
Thanks. Thanks for inviting me.
No problem, no problem. So to get things going, what would be really interesting would be if everyone could just answer this question. So this is a question that I get asked a lot, and Chris, I know that Chris definitely does. So if you were going to purchase a diagnostic ultrasound system right now, what would you go for?
This would be really interesting. Because we can't have all three, can we?
You only pick one. Yeah, just one option.
I think it depends who's going to pay for it, isn't it?
Yeah.
That's all part of it, yeah. It's an open-ended question. Right, okay, I think so that is interesting. So I think Chris will go through the wording on what each of these things mean, but can everyone see that graph?
Yeah.
Yeah.
Right, so yeah, it's relatively mixed, but portable being the most commonly chosen one. I mean, Chris, could you go into and we've discussed this previously, but how would you define each of those areas, each of those different titles?
Yeah, so if we go back 20 years, there wasn't obviously handheld machines around. So just to go through them, the handheld is exactly what it says on the tin. It's basically a probe. So some of them are wireless, so you could split handheld into two types, wireless and wired. So you've got machines like the Philips Lumify, which is a handheld machine, and most of them go up against you basically look at the image on an iPad or an iPhone or Android. So some are wireless, some are wired, but generally it goes through to an iPad or a phone, and they're obviously small. The portable is, as from the vote says, is probably what most clinicians would be using. And that's a laptop-based machine, so like a GE Logic or an Alpinion or some of the Mindrays. So they're pretty portable. Some of the machines are definitely more portable than others. I've tried most of them out, but obviously in the clinic you're generally going to put it onto a trolley, and it looks like a bit more of a cart-based. And then the last lot you've got is the cart-based machines, which are the ones you expect to see in a hospital, for example. And generally those machines are used for all sorts of imaging. So MSK, obs and gynae, et cetera, et cetera. So those are the three differentials.
And in terms of the stats that we got through there, so portable came up as quite a long way ahead of the other two. What are your initial thoughts on that?
Yeah, that's exactly. I mean, I voted portable, and that's generally certainly the guys that we teach. So we teach, physios, radiologists, less radiologists, physios, osteopaths, lots of sports doctors. sonographers, and generally when those people are looking for a machine, they'll be looking for a portable machine. And to give you an idea of price, a portable machine will be anything from 5 to 35 grand. I personally wouldn't buy a portable machine for under about 10 grand, depending on what I was going to be using it for. And that's one of the big decisions, that one of the big factors you need to look at is, what are you going to be using it for? Where are you going to be using it in terms of how portable it needs to be? And then the two biggest things when it comes to buying a machine is cost, obviously, if you're paying for it. And then the most important thing is image quality.
I think the image quality, if you work in MSK, especially in sport medicine, you need to get as good an image as you can get your hands on. From an education point of view, and get a lot out of that. But in clinical practice, if you do a lot of sport medicine and MSK, you need to get the best image you can get. So it's really challenging, and that very quickly then means what machine are you going to buy that gives you the best quality. But luckily, most machines from handheld to portable are getting better, but it doesn't mean get the best. You usually can keep your machine for a few good years now, because the machines are well built and good quality enough to last for a few years. You don't have to upgrade immediately, and they have very good second-hand ones available as well. Yeah.
Okay. And so, Chris, why did you pick a portable? And is it just because it is portable?
Yeah, so I've got 6 clinics in London. When I first started, I had to just buy one machine. That I'm on a scooter in London. So I actually bought originally a Sonosite M Turbo. The Sonosites are small. They're probably the smallest portable, and they're really robust. They're actually designed for the army. So I literally just whacked it in my rucksack and got on my scooter and went from different clinics. So that worked really well for me. And it is a good machine, but obviously in anything in technology, you're always trying to buy, you want the next iPhone, you want the whatever. So in the end, so I left the Sonosite. So I still use a Sonosite M Turbo in one clinic, and in the other clinic I use a GE Logic E. So yeah, so and they've been, those decisions to buy those different machines of, there's lots of different decisions involved in that. Certainly on the teaching, we use a lot of GE. So I was used to Sonosite, but I was using a lot of GE, and it is quite personal. So me and Rob scan on different machines all the time, and Rob might quite like the image on one a little bit more than me. So it is quite individual, and it's definitely what you're used to. So for example, the Sonosite image is actually quite different, the way it's put together and the way it looks, to, for example, a GE. So all different machines do look a bit different, as well as vary in terms of image quality.
So in terms of that then, Chris, are you saying that you get one and you find it and you stick with it? Do you find that the manufacturers tend to stick with a particular style of image or the way they present things?
Yeah, I do. I think there is something in that. I think all the machines have and it does vary a bit, but definitely the GEs and the Sonosites that I probably know most about, if I didn't see the packaging on the outside, I could probably pick out which one is which. Definitely the Sonosite, because that's got quite a different image to some of the others. What do you think, Rob?
No, I agree, and that's how it should be. And I think if you decide on what machine you get, then either try to get them at the same time from different manufacturers so you can try them out in your clinic. I certainly used to do that. I mean, my first one I bought 24 years ago, and at the time there was one portable one, which was like a heavy box, and I had to carry it around, not in my backpack, but I had a trolley for it. Having 3 or 4 in my clinic at the same time, and it's amazing how the image is different. Not necessarily the quality, but just how it looks. And manufacturers are quite clever to make it look good, especially in the olden days. They did very nice little things with the screen and made it really look good on a small screen. But the trick is, if it looks good on a big screen, and you have got a good machine and a good quality image. If it looks good on a small screen, you have to blow it up onto a big monitor or something to see what really the quality is about. So there are a few little things you can bear in mind if you start looking at machines. But the best way to do it is would literally have them next to each other. And I've done it with the GE. I've had the whole range of GEs from the Logic E all the way up to the E10 in my clinic, one after the other, literally in my room full of machines, to figure out what the difference was between each of them. And my conclusion was, They all have very good imaging, but as the machine gets better, you need to work less hard to get a good image. So it then comes down, of course, down to your skill of how good you are to be able to use the machine. So if you're a good scanner, you can use a low-grade machine and get some good quality out of it. If you know what you're doing, then if you have a good machine, it's easier. So you can argue that either way, either get good first and then buy the machine you want, or buy a good machine first, and then you don't have to be maybe as good. And I certainly, when I started 24 years ago, there were a number of radiologists who had very good machines, but not necessarily the skill to get the best out of the machines. But it was very forgiving with those big machines. So yeah, like Chris is saying, there are quite a few things to weigh up, but the old standard of putting them next to each other is not a bad one to keep. With whichever manufacturer you try to compare, or with other machines compare with one manufacturer. Yeah.
No, I think that's a really good point, Rob, because I think that the things that we people say to us is, I'm just starting out in this, so I'm just going to get something, an entry-level machine, and I know that is it's kind of in the middle there, what you should be doing. Should you be getting a better one because your scanning isn't as good, or do you just get something to start going along with?
The negative thing about MSK is that in musculoskeletal scanning, you do need that high quality if you want to get good at it, because if you have a machine that doesn't for, then very soon you either can't make a judgment on what you see, or you start guessing, which is worse. But you know, when I started with the machine, the portable machine 24 years ago, the machines obviously didn't have the quality that we have now, and you had to work it really hard to get a good image. But that maybe is good if you want to become good at scanning, because you have to work hard to do it. So if you buy a handheld machine, if you get good at scanning, you probably grow out of that machine very quickly, unless you have a specific need for that and a particular application that really works for you, and that machine does the job very well. That's fine. In general MSK, however, you would need to know what your application there is, and a handheld machine will be a challenge to get good images for general MSK. But it doesn't mean that you can't start there at all. I'd rather you start and use it as a starting point and become very good, and then you probably realize the limitations of a machine like that, rather than pretend that you're good and you can't actually see anything on the machine. So, yeah.
Yeah, good. Okay, well, on that note, I'm just going to do another poll here. So again, it's single choice, which I know is going to be challenging. So when you're purchasing a system, which of these would most influence your decision? Brand, image quality, or price?
I think I'd just say as well, with the it depends, you know, if you work in a sports team and you're a sports doctor and you're going to be traveling around the whole time, then, you know, you can see how a portable machine is, or even a handheld machine, has massive advantages. So I think as well as image quality, as well as price, I think it does depend in the environment that you're going to be using it. But, and I know Rob will agree with this, the bottom line is, you need a good image quality, because that is what you're trying to do. You're trying to diagnose the tissue, and if you haven't got a good enough image, it's not an easy skill, so you need as much help as you can. And the problem is, if you buy a crap machine to start with, when you're not very good at scanning, you're double crap, aren't you? So, you know, so you really do need, so that's the other side of the argument, is when you are at your worst, surely we all want to be scanning with the best machine to make us as good as we can. And this is where the argument is. But I agree with Rob. At the end of the day, without a machine, you're not going to get started. What's great about the handheld machines is you can just bring them home at the weekends, you know, and you can practice. Whereas sometimes, you know, the other ones, even the GE, is a little bit more cumbersome to move around.
Yeah, no, well, that leads nicely into the results that we've got here. So 64% image quality, price 40%-ish. So yeah, non-brand, which I think is quite interesting, because there's so many brands out there now. Some of them very well known, some of them not as well known. So just going into that, how do you decide which is the best for you in terms of that, Rob? Like, when you were looking at this, was brand an impact for you, or was that?
No, my starting point is usually the quality of the image, and Certainly on the portable market, there has been an explosion of good machines coming out with a fairly similar price range as well over the last few years. But if you start with the quality, and that's where I would start, the price. If you find a machine that is too expensive, but you might get one that is 1 or 2 years old and get a price reduction, that might then be your decision still to buy a second-hand one if the machine is basically the quality that you're looking for. But there are so many manufacturers making good machines or similar quality machines. So it is more, but there's less huge differences in machines, which is an advantage if you want, but it may make it difficult to decide which one you go for. It's not as straightforward. When I started, there weren't many people making portable ones, let alone good ones. So there wasn't that much choice, whereas now there's a lot more. And secondhand, like I said, there's some good ones out there as well. What do you think, Chris?
Well, it's interesting. I don't know who's on this call, but when you've scanned a bit and you've got a bit of experience, everybody's going to say image quality, and I'm not surprised to see that at the top. The problem is we teach an introduction level, and I've written this recently in a blog. We had an introduction of, I don't know, 12, 13 people, and 3 people that week had bought a butterfly machine. 3 people had turned up. So although we all think image quality is the right thing, we know generally, most of us probably know what a good image quality is. But if you do that poll before people even turn up, it will be price, I'm sure of it, because you've no idea what good image quality is. And, you know, this machine, the butterfly, me and Rob must be getting an email every week, you know, and I see it on Twitter and LinkedIn, you know, what do you think of this butterfly machine? Because first of all, it's coming up on your Facebook feed all the time, and it's only £2,000, or you know, it does add up because you have subscriptions and that sort of thing. But as I said in the blog, it's just not good enough for MSK, and the people that had bought it, you know, weren't impressed. But at the time when they bought it, they knew nothing about it, and that's the thing. And it's so important to, if you haven't scanned much, ask one of us whether what you're about to buy is a good enough machine. Because you don't want to waste your money. Because if you do waste your money, you're going to have to find the money again within a year or so, probably, but more potentially.
So on that, how do you check image quality? How do you do that?
So like Rob said, well, first of all, speak to people that are in the know. You can't check it yourself if you've no idea what a good image generally looks like, or what the image should look like when you look at the glute med tendon or the proximal hamstring, which could be considered to be slightly, obviously deeper, but harder to scan. So you've got to compare the two. But again, if you can't scan, you can't compare it. So my advice would be, don't buy a machine until you've, you know, teamed up with other people who know what they're doing, or you've been on a course, or you've gained information from one of us. I'd be really cautious, because, you know, often the ones that are really pushing the marketing they're you know, not necessarily the best machines. The handheld market is a really interesting market, because the technology is getting much, much better, whereas the handheld machines that were coming out, you know, right back at the beginning, you know, just weren't really good enough. Then butterflies come along, whereas I'd say all the other machines had been getting better in the handheld market. Yet the butterfly came out, it looks really cool, but it's just not good enough for MSK. And I know that they are going to probably develop that, and they will probably come out with a good machine. They've certainly, you know, it's a very well backed company, so I'm sure they'll come out with something good. But at the moment, it's just not good enough for MSK.
I think if you consider a machine and it is your first machine, it is tough. As certainly if you're a beginner and you haven't got the skills to really judge what a good image is. Like I said, there are a few little tricks that are in those machines to make it look better than you might think, and you really need to have a few scenarios for yourself to go through to see how good the image actually is. If you can scan it, it becomes a lot easier to see the bad and the good, and decide very quickly which is a good or is a bad machine. And that includes the probes. Some probes are bigger, have a bigger footprint than others. So there are quite a few things that you need to look at. So if you're a beginner, I would say get excited about ultrasound, go on a course, get your hands on it, because it's a very practical skill. Get excited about combining it with your clinical setting. So you're not just doing ultrasound, you try to gain more and more information about what you're going to do with that information. And once you've been on a few courses, or you know a few people with machines and you've had your hands on it, you will start to get more of an insight of what works for you in your setting. And that's probably your best way to do it, especially if it's your own money you're going to spend on it. If you have to decide it for a department in your hospital, for instance, then it's just a matter of start talking with the people who go over the budget and see what the application for it is, and then try to go from there. And again, get the best machine that you can get. And it might well be then that you don't go for portable, but more of a card-based one. Depends what situation you're in.
The other thing we find a lot as well is we'll get people that, like, first of all, you've got to definitely want to do ultrasound. You know, you've got to get excited about it. You've got to know a bit about it. And we get people that will buy a machine for, say, 5-10 grand, and they generally do want to upgrade it with like 2 or 3 years down the line, because the machine actually then does limit your progress a little bit. And then we get the other side of people that might buy a 15 grand machine straight away, and they never really have to upgrade it. So it just depends, especially at the moment. It's a cash flow issue, isn't it? So yeah.
Just to clarify on that, Chris, when you're talking about these figures, are you talking about inclusive or exclusive of VAT? Because I know that can catch people out.
It definitely catches people out. So with that, I was talking excluding VAT. I didn't have a, yeah.
Okay, now that's helpful to know as well.
But generally, you've got to remember VAT is involved in this, so you can't get away with that.
Yeah, exactly. And we've got a question from Paul Godfrey.
Yep.
So actually, Paul can ask this question directly. Hi, Paul.
Yeah, hi. I'll just pose the question. There's two, really. I've never used ultrasound myself. Obviously, I've been involved with a lot of clinicians that have, but we outsource, obviously, that expertise. But one of the things I'm on here for is because at our football club, we're obviously looking to sort of improve the medical department on an annual basis. And one area to look at this would be purchasing an ultrasound machine. But the first question was really how much training do you need? As a very experienced MSK physio, have never used ultrasound, so would need to obviously go on the courses. How much training do you feel you need to become proficient at it? And then ultimately, what's the difference in terms of the ease of which you could be trained on, whether it be portable or static? Cost may not be so much of an issue. The football club may well be in a situation where we could purchase the best that money could buy, but ultimately there's no point in having that if ultimately it spends years and years to get someone proficient at using it. The portable element is not so important from our point of view. As a professional football club, traveling with it wouldn't really be needed. Injuries sustained on a match day wouldn't necessarily be examined for a day or two later. So back at the club, back at the training ground. So a static system would be fine. But what's the differences in cost and ease of use and from a training point of view?
You want to go ahead with this?
Yeah. So in terms of cost, so if you look at, so what would be maybe considered the best machine out there is a Canon machine, which is a big static one, and that's probably, I don't quote me on this, it's probably 80 grand, something like that. So if money is no option, you get that.
I would say try a few big machines next to each other, and I'm sure they will do it, because it depends what you want to get out of it.
Yeah. So generally speaking, static machine, the big cart-based machines are going to be a little bit more expensive, but not all the time. There are portable machines for about 30k, and they could have a better image than a static that you pick up for 30k. So I mean, as I say, if money isn't a problem, go for the most. In terms of learning, at the end of the day, if you're spending around that sort of money or whatever, you're going to get a good machine. So either way, either option sounds like the machine is not going to get in the way of your learning.
You also have to think what you want to use it for, because if you, for instance, have it on site and you've got a beautiful machine there, either that means you can be quite involved with making that diagnosis, but if you get external people to make that judgment on an MRI with muscle injuries, for instance, how much do you need that ultrasound to be there for that initial diagnosis? It might be useful for follow-up or making part of the decision of going forward in the rehabilitation, but depends a bit where you're sitting on that, or is it going to be used for injections mainly? So there's a little bit of an issue about where you then go with the machine that you have. inside.
I think from our point of view, we need a very quick and accurate way in terms of diagnostics. I mean, can we use ultrasound instead of MR? And ultimately, if depending on what we're looking at, is it accurate enough? But then ultimately, one of the things would be obviously for injections. You know, in this particular field that I work in, it's all about, you know, an accurate, quick diagnosis and then, you know, suitable intervention if that's required. So I suppose, you know, yes, 80 grand, you're buying a static hospital quality level ultrasound, but ultimately you mentioned 35k for a portable. Now I don't need a portable in terms of the ability to move it, but do I need to spend 80k?
Not at all.
35 going to be good enough?
I would say if you get really good at MSK, like the guys who do the hamstring injuries and the more challenging scenario, the better quality machine, the better you can pick up the smaller or challenging details of the structure. So you make your life a lot easier when you have a good machine, and potentially the better you get at looking at those images, the more you see, and therefore the more you grow into the machine. Whereas with a portable one, you can make similar decisions, but the better the machine, like the guys who are using those high-end ultrasound machines, they indeed often either don't worry about the MRI anymore, or they still do the MRI, but they have a very good correlation with the MRI. And that you can pretty much do with a high-end machine. With a mid-range, like a 35,000, you can do it, but you may then still go for your MR to get it confirmed. So there's a slight little difficulty in terms of how confident are you going to be to use your ultrasound on that. So if you have the option, I would go for the most expensive one, because it will give you the higher quality. But if you're competent with your 35,000 pound machine, you can get a lot of information out of it, because you know how to work the machine, and you can get that information diagnostically. So it depends a little bit on your skill combined with the machine, but having the good machine helps. It's like driving a car. If you have a good Formula One race car, it does get you to the front of the finish line faster than if you have a car with mid-range, but you're a very good driver. But in the end, there's a combination of the two.
I mean, sorry, part of my question was the level of training needed to then be competent on using that, because obviously, certainly one of the things is if I can make a business case, the budget is there, we purchase a machine, then initially we may just get expertise to come in and use it, obviously in-house. That would still save the club a considerable amount of money in having to sort of outsource all the time. We're just then paying for an expert to come in and use our equipment and administer an injection on site, perhaps. But obviously, at some stage down the line, there needs to be a situation where everything's being done in-house as much as possible. So what sort of training is required?
Yeah. So this is so boring, isn't it, when people always say depends, but it depends. So on our introduction course, we go through things like Achilles tendon and patella tendon. And to scan those areas and get a good image and start looking at differentials is a reasonably short learning curve. Whereas if you're looking at proximal hamstring and looking at the fine detail of a hamstring tear, the learning curve is a lot longer. So it really depends what you want to use it for. But at the same time, if I was to put and obviously it depends, if you scan every day, you know, you're going to get a lot better at it quicker. Or if you get externals in to teach you, you're going to get a lot better at it quicker. But overall, there's no doubt that learning ultrasound, I've been doing it 12 years, Rob's been doing it over 20 years. You're learning all the time with it, and you're seeing more and more, partly because the technology is better and partly because there's a lot more research out there. But just to give you a rough idea to sort of answer the question more black and white, I quote this quite a lot. I think it takes a year scanning pretty regularly to get to a basic level of competency in musculoskeletal ultrasound. But that is very blanket, but I think that is a useful starting point to work from.
But I think you need to also consider that while you get better at ultrasound scanning, you become a different clinician, because you initially have to recognize the tissue, and that's stage one. And then stage two is recognize the spectrum of changes from normal to pathology and trauma. And then the last one will be your curve where you start. So what do you do at certain stages of the recovery of an injury? So you start to combine in the end your imaging with your knowledge of everything else that you try to figure out with this injury. And that's the beauty of it. You become a more all-round clinician. And I've done it for a long, long time. And when I started 25 years ago, talking to someone about an Achilles tendon, and I go, this is a partially rupture, or this is a non-healing post-surgical one, but with stitches in it, but the stitch is only holding it together. Or 3 months down the line, knowing that there's a partial rupture that's not healed, but has sutures in it. And the surgeon 24 years ago didn't care. Come back here, clinician that then gives you brings up a question that you have to start answering for yourself. Are you ignoring that information? Does it explain some of your groups that doesn't behave the way you think they do? So you start to get, that's the more exciting bit, when you can pass that initial hurdle of recognizing what you actually look at. But it takes, like Chris is saying, a long time. And the more exposure you have ultrasound combined with your clinic, the more feedback from other imaging, the more rounded your information becomes, and the more useful the information becomes. But I've done it a long time. Chris has done it a long time. There's always different questions that come up. And unfortunately, in sport medicine, there's a lot of things that are trends, or we think we have the information and then we don't. But that's also the intriguing and interesting bit of it. But you'll have to be committed to at least a year of integrating in your daily clinical application. And in a football club, you must have a great way to do that. We've been a few times on site with football clubs and the FA, and they all say the same thing. It's a really nice way to have that on site, but you have to commit to then indeed combine it with what you do already clinically. And if you don't do that, then either you become a radiologist, look at imaging, and you lose the connection with the patient's presentation, or you become a clinician that is not good at imaging. But the beauty of it is we can be good at both and combine them. And that is a really strong message we always tell, because when I started, a lot of radiologists were saying they were doing a good job at MSK, but they were only having a one-off meeting with the imaging of the client. They didn't have any follow-through, they didn't have any clinical information. And if you speak to good radiologists these days, they will tell you they would love to have more time with their clients to combine that information and get more understanding. So I think it's always the exciting bit, but be prepared indeed to get better and better while you're using it on site. And in a football club, you have one of the better scenarios, because you've got imaging to compare. You've got a specific group of people to work with, longitudinal, you can scan them. So I don't really see why people don't use it more. And the only thing I know from football clubs is that they use external consultants to come in sometimes to do that for them. But they, again, don't necessarily have that combination that you have as a clinician being there on top of your players. So you would either have to talk and know your radiologist and try to understand what the information they give you, or what better is to become for yourself that person that makes that judgment. That is, I think, very important. And some people are doing that very well, but it's a challenge.
I mean, it's certainly in professional sport, and we've taught at quite a few clubs this year. And what we find is we walk in and we get quite excited because they've literally got this 50, 60 grand machine, and it's just great to scan people with such a good machine. And you, as Rob said, you do see more. So yeah, and it's really interesting because you'll be able to follow it. You can follow it every day if you want and see what's happening to that hematoma. Really looking at how tissues heal, because, you know, as you know more than people, you know, these things don't have that nice linear way of healing. And actually, when you look at the structure, and I'm not saying it always fits with function and pain, but, you know, it's interesting that sometimes you know these things seem to heal really quickly, and then sometimes they just take longer and longer. And I do believe it has a role in informing our clinical decision making, just like, you know, the other barrage of tests that we have. But I do think, and in the hands of you as well, the person doing the clinical assessment. I
mean, the very high-end machines are so good these days that we see so much more in terms of anatomical detail that we query what we see. Is that spectrum of normal, or is it actually an injury? Especially football players, they might have had injuries from the age of 16, and you start looking at these guys and you see all kinds of what probably is old injuries or a variation of normal anatomy, and you realize that we need to interpret the anatomy in a way that makes sense to us, but also translate it back to the clinical setting. And those high-end machines are really opening up a new level of trying to understand. Not I think it's quite exciting, and like I said, if you're considering an ultrasound on site, you should have had it a long time ago, in my view, because you're one of the better settings to be using it.
Yeah, I think from our point of view, it comes down to cost in the first instance and making that case. Now, you know, obviously, I'm at a club that hopefully, if the season recommences, we could be successful, and there's a promotion in the offing. And then, of course, there's more money, you know, to spend. So that's where this homework is being done with that. The case for having ultrasound is a done deal. I understand the benefits of it, and having a group of players that I see every day allows me to use that on a daily basis, you know, to make a diagnosis, to follow injuries and how they, you know, heal, etc. And will add to, you know, what we do already. That's not a problem. Yeah. It's just really, how much do I need to spend? How long is it going to take me to become proficient? And it's just trying to get a handle on that aspect of things. If I can get away with 35,000, then I don't need to spend 80.
Yeah.
You know,
let's just clarify a little bit. We've talked about how long it takes to learn. I scan on a 17 grand machine. So I don't want you going away from this thinking at all that you have to have a 35 grand machine. It's just when you've scanned with that really good machine, you do see the difference. But yeah, to start with, you'd be able to get a really nice machine for around that 15 grand mark that will definitely do the job that you need it to do.
Okay. Okay.
Doing that. And Rob, you mentioned earlier on about probes and how crucial a role they play in this. So I'd be interested again, we've got another poll here, which is a yes or a no. So just to see how familiar people are with the different probes that are available. Again, another balanced one. Okay, so pretty mixed on that. What are your initial thoughts on that, Rob?
No, I can understand that people don't necessarily have a clear overview of what probes you can get. With MSK, it narrows it down very quickly. Personally, I use normally what an MSK probe, and if you get a spectrum, which is normally as low as you can get, so it's about 4 or 5 megahertz, to about as high as you can get, which tends to be sort of 15, 16 on a multiple frequency probe, linear probe. Then you've got a good MSK probe, which does most of the jobs for what you need. If you really need to do a lot of deep scanning, so hips, you might need a curved probe. But some of the machines these days have a virtual convex, which is just a button to press, and it changes a little bit of the view on a linear probe, so it makes it easy to see deeper structures. We know that some people do a lot of ultrasound on fingers and toes. For that you need a hockey stick. That's nice because it's a very small footprint, so it goes quite easy around corners, and it's very nice for the superficial details of fine structures. So you can argue with those 3 in mind, so linear probe for most of the work you do, and then a curved probe if you do deep structures, and a hockey probe if you do a lot of superficial small tissue assessment. Then you basically have got everything. But I usually have just one probe, and that's my MSK probe. And if you have one probe, some of them have a very long footprint, like the proper radiology probes have a very big footprint. That's quite nice. You get a longitudinal view. You get a slightly wider picture. But it is very uncomfortable for people that actually work around hips or the back of the knee. It can be quite painful if you have to push quite hard, and it's not so easy to go around corners with. Whereas some MSK probes have a smaller footprint, and it's just much nicer and more user-friendly. So there's a bit of a trade-off there, and some people are trained on radiology probes and prefer those large. I'm trained on a smaller probe, and I really like to be able to get wherever I want to go with a smaller footprint. But that is an individual choice, I think. What do you think, Chris?
Yeah, I think I in my clinic I have one probe, the linear probe, and that's what I do. Lots of guided injections. I do hip injections with it. I do glenohumeral joint injections with it. On the cadaveric course that I teach, we have all the probes. So I use the curvy linear and all that sort of thing. I'm definitely not as good as I am with the normal probe. So it's what you're used to, but you definitely only need one probe to get started with. I don't think people need to get too worried about it. Unless, as Rob said, if you do, we've got one of our guys that we teach who does lots of climbing injuries. So he wanted a hockey stick probe, which is a higher frequency, and you do get a better image at that really superficial level. But generally, for most physio sports docs, you can get away with one probe.
I mean, when I started all these years ago, they had a probe for each frequency. So the MSK frequency was always 7.5 megahertz, sort of bang in the middle of everything. But it doesn't mean that you couldn't really see much deeper than you want, or you don't get a very superficial, fine detail. But the multi-frequency probes these days are pretty good and cover most of the deeper tissue as well as superficial. And most machines will automatically adjust the frequency to optimize your quality of your image. So those multi-frequency probes, they vary a little bit what their start and top and low end is, but they generally do a good job on MSK. Don't forget, in MSK, you normally scan relatively young people with good anatomy, relatively, especially in sport medicine, if we do that a lot. That 60, 70, 80-year-old in the NHS, quite often you come across those, then a normal MSK probe would become quite difficult to use, especially
Okay.
Yeah.
Good. Anything to add on that, Chris?
No, not at all.
So we've spoken about the technology, image quality, etc., and branding, but there's also a lot of other things that are surrounding that. So we've got another poll, which is, again, one option only, and this is about some of the surrounding things which go alongside the technology itself. And so if you could just answer what you would value as being the most important within that. I toyed with having all of the above on, but it was too easy. So
Yeah.
we decided to take that one out.
I suppose I'm a bit biased because I run lots of training, but the biggest scare for me, for physios, sonographers, chiros, osteos, all these people that essentially can go out and just buy a machine, you know, with no training and get started and start advertising that they're doing it. That's my biggest worry. And unfortunately in this country, there's very little regulation. There's very little competency-based training. There's very little standards out there to what competency-based training you need to do. And I think that needs to change. There is stuff in the background happening, but I can't see it getting too far because of all the different groups that are trying to learn it. Because ultrasound, if you go to the States, ultrasound in itself is a speciality. You know, it very much is, you know, there's lots of people that are just going down that route. And I think and hopefully in this country, I'd love to see that there is a basic level of training that everybody should be doing before they start, I'm not even interested in calling themselves anything. I'm just interested in saying, do you know what, I've at least done this, and therefore, you know, I'm on the right path to becoming competent. The biggest thing is you don't know what you don't know. And we get people on our intro course, we get radiologists, we get sonographers, and the standard of scanning is just not very good. And unfortunately, they don't always know that they're not very good. You know, you say, right, find the ATFL, and they're literally nowhere near it. And it's like, well, how long have you been scanning? Well, I've been doing this for about a year. You know, it's worrying. And that, I think, as I've got better at scanning, you know, I'm always questioning, right, who did the scan? Who did it? Show me an image. You know, what's the report say? And actually, I want to do the scan myself. Obviously, I work with lots of guys that I really trust, but you want to see that image. And obviously, that is quite subjective, but at no point should we think that MRI isn't subjective. Yeah. Reporting on MRI varies a lot, and we need to keep questioning what we're doing and hang our hat on our clinical assessment. If you think there's a labral tear in that hip, you know, and the MR just comes back clear, ask them to re-report on it. I've got loads of cases where that's the case. Depending on, you know, if you work in a sports team, you generally know your radiologists. You can have an open conversation with them. But if you send them off to some private clinic in London, I don't know, and you've never even met the radiologist, then you've really got to keep questioning what we're seeing. But that's what makes us better clinicians.
To come back to the manufacturers and the machines, sorry, Chris. If you buy a new machine, the manufacturer should send someone over to help you set your presets, your preferences on the machine. If they should set it up for you. And I have used machines, you know, portable machines over the years. I've never really had any of the machines breaking down. I had to replace one of the batteries, I think, on it. But you don't really need to go for extended warranty or anything like that. Those machines normally look after themselves. unless you are in a department where 10 or 12 people, you all use the same machine, you never know where the machine ends up or who's using it. You just want to make sure that if something goes wrong, that it can be fixed quickly. But you don't really need extra warranty or spend a lot of money on extra care afterwards. They should actually just set it all up for you, and if you have any problems with it down the line, they should immediately just with customer service or the technical side of these guys. I do it sometimes and call them up and say, what about this, what about that, and they will be able to help you over the phone. So it's quite straightforward. I think don't spend extra money if you not have to. You don't need to do that.
Yeah, I mean, the responses backed up what you hoped for there, Chris, with education coming out well on top. Everyone as well there. Yeah, and then a couple of comments on in the comments section about manufacturers mainly providing just showing how to use the device rather than actual training. So any thoughts on that, Chris? What's your experience?
Yeah, so my experience is that most manufacturers don't have an MSK expert that they will send out to set up your machine. So, you know, I think some do, some don't, but generally speaking, certainly when I've bought machines, I've got somebody that's very useful at helping with the knobology and setting some presets, but it's very rare that you'll get somebody that actually has a MSK specialism that will come out.
Okay. Yeah.
I agree that they don't have training packages, and they won't do that. Like I said, the people that come up and set it up for you, the ones I've met, they do really good job to setting up my presets. They understand what I want out of it. One or two of them have done specific programs for muscle and tendon scanning that I asked them to do, for the hip a special one, for the knee a special one. And they came back once or twice, and if they didn't know the answer, they would sort it out in the background and do it for me. But that is different to providing training. And as Chris is saying, it takes a while to get good at it. And manufacturers don't have that in their packaging. They leave it up to you to decide where you get your knowledge from. And maybe that's good, because if they start, unless they start doing a proper program for MSK, just a weekend introductory course, once you have your machine, doesn't really get you further. You need to have that follow through from that stage. But we hear that all the time when people come on our courses. They get excited about a machine and they don't know where to go from there. I like to think that we can help with that. It's a very practical skill. So again, you need to be able to be involved and get practical with it. So our courses are quite practical. You can't just get it from a YouTube video. It's not like DIY. You have to actually be supervised and learn how to do this. And from the beginning, so you need to know first what is normal before we can discuss what abnormal and injury looks like. And that's a whole journey to go through. Yeah.
Yeah, and then we've got a comment from Douglas about the paying extra for, and then proper training with case accredited course with the scanner. Any feedback?
Yeah. So I think I mentioned this on the webinar, and I totally agree with Doug. Hi, Doug. Hope you're well. The problem is the gold standard of training is a postgraduate certificate, case accredited in this country. However, a large percentage of people cannot get a clinical supervisor. So we can't just say we should all do a case accredited course, because unless somebody is going to do a separate clinical supervision program, of which we do with SMUG, we do the mentorship program, then basically the people that can't get a clinical supervisor are just out doing their own thing. So unfortunately, the PG cert, although I would agree we should go for that as our gold standard, there also has to be other options. Do you agree, Doug?
Thank you for unmuting me. And hello, everyone. Yes, I do. This is one of the biggest problems, is the issue of mentorship. And how you can do that well. Case accredited courses are, as you say, they're the gold standard. And one of the things that I think is missing from this whole picture is a structure that leads up to that in a more formalized way. Case accreditation is difficult to achieve. It's academic, and you do need to have a better structure for people to gain and acquire skills that lead towards that, I think.
Yeah, I mean, can't
My
disagree with that.
concern.
The other thing to mention on that is we get, I mean, God, on our mentorship this year, we must have 4 people that have completed a postgraduate certificate. And then at the beginning, they really weren't very good. So although it's the gold standard, it definitely doesn't guarantee standards. So it unfortunately becomes a tick. You can see I've got a bit of a bee in my bonnet about this. It becomes a bit of a tick box exercise. So people turned up with their 250 scans all signed by somebody, but they can't scan. You know, we can tell if somebody can scan. It's a bit like sitting in a car or watching somebody play the guitar. You can work out whether they're decent at playing the guitar quite quickly or okay. Whereas, and it's the same with ultrasound. You can either find it or you can't. And so, yeah, unfortunately, the PG cert, great, do it if you can. If you can't, make it happen through another option. And at no point do they guarantee standards. They try to, but unfortunately, it doesn't always do that.
And when we do our patient clinic once a month, and we do that for a mentorship group. So the people on our mentorship are clinicians. They are experienced clinicians. And it's very interesting to see how an experienced clinician puts the ultrasound in the room with the patient and actually starts to combine what we have taught them through our intro courses and the advanced courses, how they're actually going to then translate the findings of an ultrasound in clinical setting with the patients there in front of you. And it's even at that stage, when they are PG certified, when they have used ultrasound for quite a long time, how it's very different to see an ultrasound scan. It's a totally different thing to then translate that into the patient in front of you and gain information that you're going to be using. And I find it quite intriguing because I think for them it's a step up to have someone overlooking to combine those things. And I think even that last step, you don't get from PG cert at all. And people on a mentorship really enjoy that part of it, application of ultrasound in the clinic. And I think that is a big part that is missing. And if you having that supervision or even discussion with fellow mentorship students is very useful. It's very useful, and it's not a given that once you're good at ultrasound that you know how to translate that for your patient in front of you. What are you going to do with that? And I think it's very sad that the PG cert is a gold standard that in MSK is not necessarily the standard that we really need to be good at combining ultrasound in clinic. It's different if you do a sonography clinic and you just report on an ultrasound, but translating it back into the clinic, that bit is a very big challenge for a lot of people we come across.
I've written quite a few things on competency on the website, so if anybody's interested, but basically if you can't do a PG cert, you do need to define your own competency within your clinical setting. So for Paul, who works in football, his competency is probably going to be lower limb to start with, and he might just focus on certain areas. So you can learn this through a modular based system. So for 6 months, Paul may just say, I'm only going to scan the quads, the calf, the Achilles and the patella tendon. Get really good at that, keep practicing. And then once you feel you get good at that, then go on to the hamstrings or something like that. So you can break it down into these tasks. What you must do is keep a logbook of scans. So if somebody has any issues with, well, why are you scanning? What's your competency? You need that evidence, that portfolio of scans. So if you've got a machine, you need to start writing reports. You need to start collating your evidence of your competency.
Great, thank you for those. So we've spoken a lot about the technology and pricing around that, then talking about the training as well as obviously cost implications for that. So I think a big question that we're constantly asked, and I know is spoken about with everyone involved in this, is basically how you make a return on this. So it's an investment, and how do you make that? Our friends in Holland were asking that question where they don't get paid any extra for those for doing scans.
Yeah.
So seeing that, Chris, I'm just going to launch this poll and see if people know how they're going to generate a return. But yeah, go, Chris.
Well, I know how I'm doing it. There we go. Okay, so so generally in the UK, generally a physio, an osteo, chiro, most of the guys that I've taught and that don't charge for a scan. Okay, so, and certainly, so that's one thing. I make my money out of ultrasound guided injections, so I get lots of referrals from different people who will say, "Oh, can you do a scan?" or "This person's not getting better." So, a percentage of that, or a lot of what I see, people will send me 5 frozen shoulders a week or something like that. So I monetize it off my guided injections, and that's fine for me. You can charge for an ultrasound when you get to, in my opinion, when you've got to a basic level of when you've got to a good level of competency, which in my opinion is 2 to 3, this is rough figures, 2 to 3 years of scanning, and or a PG cert or some sort of training program. However, the important thing is you never charge for the ultrasound on its own. This is just an extension of your clinical assessment. So I've never actually done this, but something I've thought about for years is, if somebody comes to me, instead of charging the 75 quid that we would charge to see me or one of my other physios, I might charge £120, which includes an ultrasound if appropriate. So I'm not separating it from what I do. It's just, I just so happen to scan, and this is the assessment process that I go through. Does that make sense? So then what you're doing is you're providing a service which happens to include an ultrasound scan. The next question is, should you write a report? Well, as somebody that does lots of scanning, I'll write a report on every patient, but the report is never separate from my letter. So it's just part of my letter. I wouldn't just send an ultrasound report on its own, because to me that makes no sense. This has to be part of the clinical context. So that's, so that's my answer on the return on investment.
When I started in '96, and I made an effort not to charge ever, because basically I was never want to be in a position where people can say I just scan because I can charge for it.
Yeah.
But as Chris was saying, I just upped my price, and the patient can either see my colleague or they can see me. And if they see me, they can get an ultrasound. But that is up to me if it's still necessary. So you get sort of a higher fee for yourself if you do ultrasound. These days, that is not so easy if you have to deal with insurance companies, because they don't really recognize that as being possible. So the fees, you can't apply that structure. But if you have the option, you can indeed just charge more for the assessment. But as Chris is saying, always combine it with your clinical assessment. Not only is that important to make a conclusion, it also stops you from being a sonographer. But if you work in Holland, and we have had people at different places in Europe, insurance companies or health systems look at it in a different way. So it can be quite tricky to see how you can set yourself up for that. But I know in the UK it used to be you can set your own fee, and that's how I started. Just up my price. And people they come specifically to me to have an ultrasound done, or they come through the recovery. They come back if they want to have a follow-up for that. So you get sort of your clientele becomes more specific for ultrasound, MSK ultrasound, and they are prepared to pay extra for that if you can set it up in your clinic. If you do guided injections, you can of course then sometimes charge for that. There's a fine line, especially in the UK. We have seen quite a lot of sports doctors using that pathway where if you can charge for guided injections, it becomes a very low threshold to then do guided injections if you can charge nicely for that. So this is of course a little bit of how far do you go to do guided injections without going a little bit too far, especially in private practice, and just make every patient that comes to the door have a guided injection. And I've seen some clinicians quite keen to use that as their way of getting money. So become a good clinician and decide, and then your reputation hopefully will take you quite a long way in that. Certainly worked the way for me.
Yeah.
Once you've scanned, you don't want to be in a decision. You don't want to be in the clinic where somebody's got an Achilles or a hamstring, and all ultrasound does is just give you more information from your clinical assessment. I want as much information as I can when I'm in the practice. So I don't want to go, well, I've got this ultrasound machine for another 40 quid. I could put this on your leg. Yeah, you don't want that. You just want to gain as much information as you can. The other thing to bear in mind is we're not offering an ultrasound clinic service. You don't want to be scanning lumps and bumps. You don't want to be scanning hernias unless you do lots of them. So we are not providing an ultrasound clinic service. If you are, in private practice, you need CQC, and you need a formal, safe, secure way of storing all your scans. I looked into all of this because obviously I could set that up, but decided not to due to the costs associated with doing that in private practice.
Okay, good, thank you. So I'll show you that. So just to share the results quickly. So 58% don't know how they're going to do it. So that's obviously a challenge that people need to consider when they're looking into this.
Especially when you're selling machines, Andy.
Well, yeah, exactly, yeah.
The difficult one. Yeah. The good news is I think most clinicians do, I still believe that lots of us just do this off pure passion anyway. So, you know, I think there's still, that's why we buy it. Why do I spend all this money on machines? Not because I've ever sat down with an Excel spreadsheet, just because I believe to do the best and to enjoy my job the most, which is probably much more important to me, is that I've got the energy to turn up every day, and having ultrasound in the clinic does that. I'd hate to not have it.
I think in sport medicine, ultrasound has a good place. It has its limitations, and we need to know that as well. But the ultrasound has now become quite a normal feature in a lot of sports physicians' hands. And it should be, because like I said, like Chris is saying, it's an information gathering tool, and you just need to see it as that. It is indeed important to know, you know, do you get your money back for the machine or not? How are you going to set it up for yourself? And do you have the clientele? Do you have enough people that you use the MSK ultrasound for as well? That depends, of course, where your setting is. So quite a few things you need to consider indeed. But it's not a quick fix or to get money. You don't start ultrasound to make a lot of money, unless, like I said, you do a lot of expensive guided procedures, and you can be quite good at doing so. But there's a specific pathway that people sometimes use, like pain management, pain specialists, or some specialists just do shoulder injections the whole time. You can get radiologists who do that a lot, but that's a very specific part of that.
There's a question there from Mark, how the lifespan of a machine. When I first started, I bought 4 M-Turbo Sonosite machines, and this is over 8 years ago. And the only thing that's changed, the only thing I ever have to do is buy a battery now and then for 300 quid. So the lifespan of the machines are generally good. Obviously, the probes are pretty delicate. There's lots of crystals in there, so you know you need to make sure that you do look after it. But generally, certainly with my machines, they've had a good lifespan.
My machine from '96 still works. It's in my clinic. I don't use it anymore, but it's still there. That's 24 years. Still works.
Right. Okay, so we're pretty much done on the general overview of what we were doing. We've got a couple of other questions that have come through to us beforehand. But this is from a podiatrist, but they're considering what they want to do in private practice, and they were wondering are there any systems which are more suited to different professions?
Yeah, I mean, it's not profession specific, it's location you're scanning specific. So we do lots of work with podiatrists, and generally what they're scanning is more superficial than other areas of the body. So potentially they can get away, for want of a better term, with a lesser machine. But what we've talked about still exists, that we still want to get the best image quality, because if you look at the fine detail of the foot, so if you want to look at the calcaneal nerves, if you want to look at the spring ligament's quite big, but if you want to look for a small Morton's neuroma, which I do lots of, you know, we are looking at very small structures there. So although I would suggest, because they're scanning superficial structures, they can get away with a little bit more. If the detail you're after is what I've just talked about, those small nerves, then you need a really good machine.
And quite likely also a hockey stick, because it gets you around all the little corners of the toes and things like that. So a hockey stick as a practical application of the probe, which then normally has a high frequency, so that gives you a better image. Generally.
Yeah. One thing I would add is, as Rob alluded to earlier, is a lot of the machines have a different size probe. So you just need to be aware of that, because sometimes on the courses we have a bigger probe, and getting round the ankle can sometimes be a bit trickier. So yeah, probably the size of the probe, the footprint of the probe, as we would say, is something to consider as well.
Okay, and then we've got a question. So Rob, how much do you use Doppler within an MSK examination?
I use it usually as an extra layer of information, but Doppler is very subjective. The studies that came out when Doppler became very fashionable were all sort of a bit like anything when it comes out. You know, when the technology goes into the lower end machines, everyone starts using it and becomes excited about it. So from the neovascularization being the latest, now people going away from that again. I think it is useful if you see neovascularization or an increase in vascular activity around tendons or in tendons. There is some process going on there, but how you're going to interpret that back into your clinic is one thing. And also bearing in mind that if you scan, for instance, the tendon, if you put it under stress, that Doppler signal often goes. Like an Achilles tendon is a very good example, or infrapatella. So unless you are aware of that, you can become very subjective in your findings in Doppler. So your machine can be very good, and you have to have a good machine with a good Doppler sensitivity to make judgments, but also how much pressure of the probe, what the structure, what state the structure is, it stretched or not, and if you repeat it, you have to repeat it in the same way. So it's very subjective, but it can sometimes give you a little bit more information. So that hypoechoic area deep in the infrapatellar tendon could just be vascular. It could be just vessels opening up, and that might be, if you put a Doppler on, that it shows it's vascular and that it's not an hypoechoic lesion on its own. So it could help. So I use it sporadically and know the limits of it, and I think that's how you should use it. Unless you are working in rheumatology or you're working with a specific group of people, then you have to make sure that you have a very good Doppler machine, especially with rheumatology, and that means an expensive machine. Then you can start to maybe see more consistent information you get out of Doppler. But then you have a very specific group of people you work with. In sport medicine, that is not the case.
It's very machine dependent. So I've done this lots. So if I've got my sonocyte, I don't think my sonocyte Doppler is very good. My power Doppler, I do lots of tendon work, whereas the GE Logic seems to pick it up quite nicely. I've compared that to a few different handhelds. I tried the Clarius new handheld, and that seemed to have a pretty good Doppler. So it does vary.
I've done a few studies.
But I certainly use it. It's a great tool to have. You know, if I was to buy a machine, I wouldn't buy it without power Doppler.
Because I've done it with my clients, and you can do it with one client. You do it when they lie on your couch, say the infrapatellar tendon, and you see the Doppler activity, stand them up, do it again, do it after a few exercises, and then do it next time you see them again. And you'll find quite a variation of Doppler signal, even if you use the same machine. So just be aware of the subjectivity of it, but don't throw it out. And it's the same with elastography. If you get elastography on a machine, don't just buy it because it's there. It needs to be, if you want to really use it, it's still very challenging, but you then have to have a very expensive machine that probably has to be optimized for that technology to get any information out of it. So don't just buy the elastography as an item on the machine. Don't do that at all. And the same with Doppler. If you really need it, you have to get a good machine, and I'm afraid that means it's expensive.
Petra, does that answer your question? 1 second. Hi, Petra.
Yeah,
okay.
Yeah, you hear me now?
Yeah.
Yeah, no, I fully agree what they say, but it's been quite pushed here in Holland by other companies that you should buy a machine with Doppler, but we find it's not that relevant. Mm-hmm. So I was really curious how, well, the English guys felt about it, but it's quite similar how we feel about it.
It certainly should not be the case that with any machine that you start to make a judgment just on the Doppler. That is long gone. All that neovascularization, and then you do an injection and it's gone. That sort of thing is not really black and white. You need to look away from that. But if you have a good enough Doppler on your machine, using it is not bad at all. Just don't hang up everything onto it.
Exactly. Yeah.
It depends what we're talking about, doesn't it? If we're talking about rheumatology and synovitis, or are we talking about tendons and neovascularization? So it really depends what group of patients you're scanning.
Yes, and for us, it's most the physiotherapists. I fully agree with the rheumatologist, they cannot live without it. But for a physiotherapist or a podiatrist, it's not essential to have it. It's beneficial to have it.
But it depends if we're talking about color or power.
They promote it as color, but I think they need.
Okay. I mean, it can be useful, particularly when you're doing injections, to make sure you're not going into a vessel. But
Yeah. Then I think when you want to do something like that, then you need it. But the physiotherapists in Holland are not allowed to do it.
Oh, okay.
So.
Great, thank you. So yeah, we've overrun a little bit there, but what would be really helpful is we've spoken about a lot of information there. Could you both just give your parting points on what one main thing that you would say, Rob, as a take-home message for everyone who was looking to buy a system?
If you're looking to buy a system and you're a total beginner, as we discussed, it might be worth holding back or exploring a few, prepare it a bit, but don't commit immediately. Just get excited and go on a course, an intro course, and then decide. If you're going to buy one with the quality in mind, I would say, if you look at a lot of MSK applications. And there are quite a lot of them out there, especially in the portable level. There are a lot of them that are quite similar in quality, but pick the one that really suits you, try them out. And if you go for the high-end one, you probably have to, exactly, you get what you pay for. So there's still quite a few options there. So again, get them, it's annoying, but get them in your clinic if you can, to try them out. Don't buy it before you even have tried it. If you're not a beginner and you really just look at what machine do you want, you need to look at your clinical setting, and if you're competent, then go with that's it.
Chris, anything to add to that?
No, just if you're not sure, just ask, drop us an email or anything like that. You've got to try before you buy, and often, don't think about it as just a machine purchase. Think about it machine plus training. I know if say I had 20 grand or 10 grand, I'm not saying I would buy. I would factor in the cost of training into the machine, because you can buy whatever machine you like, but if you're not getting the right input, then you're not going to get the best out of that machine. Obviously, I'm biased because I run training courses. However, you get so much more out of the machine when you're trained properly. So.
Great. No, thank you very much, guys. Chris, Rob, it's been really good having that information sent over to the guys there. So what we'll do is Mary will send out some information following this. Chris and the Smug guys have got some great resources on their website, so we'll send that out if it's okay with you guys. Some of the blogs that you've got will definitely answer some of the questions that have been asked here today. Yeah,
well, if people want to talk to us, we ring. I'm more than happy to speak to people. The worst thing you can do is buy a crap machine. Or buy an old second-hand machine with no warranty. That's the other thing we haven't talked about. Don't get on eBay or anything like that. You occasionally get a good bargain, but yeah, just ask.
If you buy a second-hand one, contact the manufacturer, because they often have ones that have been returned, and they're normally a few years old, and they normally don't go out unless they've checked them out. So to the manufacturers, there's a lot of second-hand ones that are still quite good as well.
But you need a warranty. 1 year. At least.
Great. No, thanks again for that. We'll send out an email tomorrow, which will also have some feedback in there. So if you could fill that in for us, that'd be really helpful for looking at what topics for future webinars. So Chris, thank you very much. Rob, thank you very much. And thank you all for joining, and we'll speak to you soon.
Thanks, guys.
Thanks, guys. Thanks for joining. Thanks.